Okay, good morning, everyone. So today, very important topic. I think I have come across so many times pregnant patients in malignancy, and it is still to be defined that what exactly we should do, because there are so many components and so many factors involved when a lady is pregnant and diagnosed with malignancy. And I'm so happy to see this topic we are discussing today. And the discussion will be held by KMC Manipal and under the moderation of Anuja. Anuja Damani, Dr. Anuja Damani, we all know. We all have seen her working in the recent Bangalore conference under the leadership of Naveen and Seema. I think we all know, so there is no need to introduce Anuja, but still her major achievement, which I can say that all sorts of grants she has already received, that ESMO travel grant, American Association of Hospice and Palliative Medicine scholarship, and Idea Palliative Care Award. I think which youngsters definitely should look for all these awards. And her area of interest is chronic pain and symptom management and education and training, which we have witnessed in Bangalore conference, and renal supportive care. On personal note, as she's a first MD palliative medicine student of this country with Arun. She's very I think everyone of the whole country likes Anuja and Arun a lot, and Anuja is working so hard since last so many years to develop palliative medicine in this country. So Anuja, please introduce Avasti and go ahead with this important topic. I think even I am looking forward what exactly we should do and what we should not do. Go ahead.
Thank you, ma'am. Thank you for the kind introduction. I would like to introduce Dr. Aswathi Praveen. She is a second year postgraduate student at KMC Manipal. She has key interest in myofascial pain patterns in head and neck cancers. That is her thesis topic, and she also likes to work around ICU palliative care. And this is a very important topic, as we all know that we come across such patients, but we are clueless how to deal with them, as Madam has already said. So we would like to hear from Aswathi about a few insights into how to manage pain in pregnant females. Thank you. Aswathi, can you share your screen, please?
Yes, ma'am. Good morning. Today, I will be discussing the topic pain management in pregnant patients with malignancy. It under common cancers in women of reproductive age group, causes of cancer pain in pregnancy, metabolism of common analgesics used in cancer pain, physiological changes in drug metabolism in pregnancy, maternal to fetal circulation barrier and drugs crossing the barrier, analgesics used in 3 trimesters of pregnancy, analgesics affecting the fetal development. As per this article of Demographics of Cancer in Reproductive Age Female, cancer in reproductive age women represents a significant source of morbidity and mortality. The treatment of cancer in this age group, whether it entails chemotherapy or radiotherapy or surgical resection, it often results in survivors with impaired or absent reproductive potential without assisted reproductive technologies. Breast cancer is commonly seen in patients of reproductive age group, followed by lung cancer and colorectal cancer, which are more commonly seen in elderly patients, but occur within high frequency overall. Cancers of female reproductive tract, particularly carcinoma cervix, are also seen in women of reproductive age. The common leading causes of cancer death in women is because of lung cancer, breast cancer, and colorectal cancer, as per this article. Moving on to cancer pain, the different types of cancer pain include nociceptive pain, which is caused by noxious stimulus to the somatic or visceral organ, neuropathic pain, which is arising from the abnormal neural function as a result of direct damage or indirect insult to a neural tissue, and mixed type of pain, which is combination of nociceptive and neuropathic pain, which is commonly seen in cancer pain. Some of the causes of cancer pain include tumor effects like local mass effect, metastatic disease, cancer-induced bone pain, paraneoplastic effects, central sensitization, Treatment-related cancer pain like surgery, chemotherapy, radiotherapy, or other treatments like steroidal therapy, hormonal or immunotherapy. Various associated conditions like hypercalcemia, osteoporosis, prolonged immobility, immunosuppression, like infection or herpetic reactivation could result in pain, and pain unrelated to cancer, which is associated with musculoskeletal conditions. Pain due to cancer, especially in advanced or metastatic disease, may have various etiologies and underlying pathological mechanisms, and correctly understanding these will provide most efficient and tailor-made treatment strategy. Some of the common analgesics used in cancer pain management are non-steroidal anti-inflammatory drugs, paracetamol, opioid analgesics like morphine, fentanyl, methadone, buprenorphine, and adjuvant analgesics like tricyclic antidepressants, selective serotonin or norepinephrine reuptake inhibitors, gabapentin or pregabalin. Metabolism of common analgesics. Non-steroidal anti-inflammatory agents. As we all know, the mechanism of action is prostaglandin synthesis inhibition. NSAIDs prevent or reverse inflammation-induced hyperalgesia locally and in the central nervous system, thereby reducing the pain. Inflammation associated with increase in prostaglandin production in peripheral as well as the central nervous system. Peripheral free nerve endings responsive to noxious stimulus become hypersensitive in presence of inflammatory substances, thereby increasing transduction and resulting in increased pain. Increased prostaglandin production in central nervous system in response to the noxious stimulus leads to central sensitization of neurons in dorsal horn. Cyclooxygenase 2 plays a key role in central hyperalgesia. By inhibiting the production of cyclooxygenase, NSAIDs block the synthesis of prostaglandins both peripherally and in central nervous system, thereby reducing the pain. Evidences from several randomized controlled trials suggest its benefit in pure neuropathic pain. However, neuropathic pain in cancer typically is a mixed nociceptive and neuropathic pain. Paracetamol. It is a synthetic, centrally acting non-opioid analgesic and antipyretic, and it is also a weak inhibitor of cyclooxygenase. The metabolites act on supraspinal centers like periaqueductal gray, causing activation of descending serotonergic inhibitory pain pathways. Acetaminophen, it is extremely metabolized in the liver where glucuronidation and sulfation are the common pathways. About 5 to 10% is metabolized by the CYP450, primarily by CYP2E1 to toxic metabolite called as N-acetyl P-benzoquinoamine. At therapeutic doses, it is inactivated by conjugation with glutathione. After formation of acetaminophen glutathione complex, it is converted further to acetaminophen cysteine and then later to acetaminophen mercapturate. Without this detoxification, N-acetyl P-benzoquinoamine binds to the cellular proteins covalently to form toxic protein, causing mitochondrial dysfunction and oxidative stress. Opioids. Most opioids undergo extensive first-pass metabolism in the liver before entering the systemic circulation. First-pass metabolism reduces the bioavailability of opioid. Opioids are typically lipophilic, which allows them to cross cell membrane to reach target tissues. Drug metabolism is ultimately intended to make a drug hydrophilic to facilitate its excretion in urine. Phases of metabolism. Phase 1 typically subjects the drug to oxidation or hydrolysis. It involves cytochrome P450 enzyme, which facilitate reactions that include dealkylation, aromatic aliphatic or N-hydroxylation, N-oxidation, sulfoxidation, deamination, and dehalogenation. Phase 2 metabolism conjugates the drug to hydrophilic substances like glucuronic acid, sulfate, glycine, or glutathione. The most important phase 2 reaction is glucuronidation, catalyzed by the enzyme uridine diphosphate glucuronyl transferase. Glucuronidation produces molecules that are highly hydrophilic and therefore easily excreted. The table shows metabolic pathway or enzyme involved in different phases of metabolism of opioids. Majority of opioids undergo phase 1 metabolism. CYP3A4 is primary metabolizer of fentanyl and oxycodone. Tramadol undergoes both CYP3A4 and 2D6 mediated metabolism. Methadone is primarily metabolized by CYP3A4 and 2B6. Morphine, oxymorphone, and hydromorphone are metabolized by phase 2 glucuronidation and has less potential for metabolically based drug interactions. Physiological changes in pregnancy. The main physiological and anatomical changes are depicted in the image. In gastrointestinal system, there are high levels of progesterone, which cause smooth muscle relaxation, reduced bowel mobility, and thus prolonging the gastric emptying time, leading to constipation. Progesterone-mediated relaxation of lower esophageal sphincter produced decrease in its tone and manifested as gastroesophageal reflux disease. In renal system, the renal plasma flow and glomerular filtration rate are increased. Increase in GFR maintains the plasma sodium level, which increased because of activation of the renin-angiotensin-aldosterone system, and it lowers serum creatinine and urea. Elevated progesterone reduces peristalsis, urethral tone, and contraction pressure, producing renal vasodilatation. In endocrine system, there is increase in the level of estrogen, progesterone, total T3, T4, cortisol, ACTH, and prolactin. In cardiac, the heart rate increases up to around 60%. Cardiac output as well as stroke volume also increases during pregnancy. In respiratory system, diaphragm rises by around 2 centimeters, leading to 5% decrease in lung capacity. The volume increases up to 40%, leads to decrease in expiratory reserve volume by 20% and increase in ventilation per minute. There is increase in partial pressure of oxygen in the artery and alveoli and decreased partial pressure of carbon dioxide in artery as well as alveoli. In musculoskeletal system, there is increased lumbar lordosis and joint laxity. Hematological, there is increase in plasma volume by around 50% and erythrocyte volume around 30%, leading to physiological anemia. There is increase in leukocytes, fibrinolysis as well as coagulation pathways undergo changes, and venous stasis lead to increased risk of thromboembolism. Physiological changes in drug metabolism in pregnancy. Pregnancy is a complex state where maternal physiology have evolved to favor the development and growth of placenta and fetus. In turn, it affects the drug dosing and effect by altering the pharmacokinetics or pharmacodynamics of the drug. It is important to understand the physiology and gestation-specific pharmacology of drugs to achieve effective treatment and limit maternal and fetal risk. Drug absorption. Drug reaches the target tissues at sufficient concentration to exert the therapeutic effects without causing significant adverse events. Nausea and vomiting in early pregnancy decrease the amount of drug absorption following oral administration. Therefore, medication should be administered when nausea is minimal. Gastric acid production decreases and mucus secretion increases. This in turn increases the gastric pH, increase ionization of weak acids and reduce their absorption. Slower intestinal motility and decreased gastric acid secretion could alter the drug absorption and oral bioavailability. Coming to drug distribution, cardiovascular changes during pregnancy include increase in cardiac output, which is starting in early pregnancy, plateauing by around 16 weeks to reach around 7 liters per minute and remain elevated until delivery. A parallel increase is noted in stroke volume, which start to increase by around 20 weeks of gestation, and a gradual increase occurs with maternal heart rate reaching 90 beats per minute at rest in third trimester. Approximately 42 to 50% increase in plasma volume, reaching over 3.5 liter over 38 weeks of gestation, with parallel increase in total body water and in all body fluid compartments. Expanded extracellular volume and total body water will increase the volume of distribution for hydrophilic drug, leading to lower plasma concentrations. Maternal body fat expands by approximately 4 kg, increasing the volume of distribution of lipophilic drugs. Plasma protein binding of drug decreases during pregnancy due to reduced concentration of both albumin and alpha-1 acid glycoprotein. Decreased protein binding leads to higher concentration of free drug and favors more distribution to tissues. Drug metabolism. Oxidative phase 1 reactions are predominantly carried out by cytochrome P450 family of enzymes that differ in their substrate specificity. The activities of CYP3A4, 2A6, 2D6, and 2C9 are all increased in pregnancy, and CYP1A2 and 2C19 appear to undergo a gradual decrease in activity with advancing gestation. Maternal to fetal circulation barrier and drugs crossing the barrier. Optimal development of the embryo and the fetus depends on placental passage of gases, nutrients, hormones, and waste products by passive diffusion, carrier-mediated cellular uptake and efflux, and transcytosis pathways. The same mechanisms control the rate and extent of transplacental transfer of drugs taken by the pregnant mother. Essentially, all drugs cross the placenta to a certain extent, and some accumulate in placenta itself at levels that can even exceed those in maternal plasma. Drugs that are not efficiently transferred across the placenta may indirectly affect the fetal development by interfering with placental function. Mechanism of transplacental transfer of drugs. The syncytial trophoblast is the functional part of the placental barrier. Three main processes mediate the transplacental passage of substances across the intact placental membranes, namely the passive diffusion, carrier-mediated transport, and transcytosis. Placental drug metabolizing enzymes. The human placenta expresses enzymes that catalyze both phase 1 and phase 2 reactions. Phase 1 include drug oxidation, reduction, and hydrolysis, and phase 2 include conjugation. Placental cytochrome P450 isoform protein include 1A1, 2E1, 3A4, 3A5, 3A7, 4B1, and 19. At the mRNA level, the major isoforms detected in placenta are placental aromatase CYP19 and CYP11A. Additional phase 1 enzymes detected at term placentas include alcohol dehydrogenases, epoxide hydrolases, and N-acetyl transferases. Placental phase 2 enzymes include uridine diphosphate, glucuronal transferases, glutathione S transferase, epoxide hydrolase, N-acetyl transferase, and sulfotransferases. Placental CYP19 is involved in metabolism of buprenorphine and methadone. Moving on to pharmacological treatment of pregnancy. As per Food and Drug Administration, pharmacological risk categories in pregnancies of various drugs are categorized to 5 different categories. Category A is controlled studies show absent risk. Appropriate well-controlled studies in pregnant women show no risk to the fetus. In category B, there is no risk of evidence in humans. Findings in animals has shown risk, but not in humans, or if adequate studies with humans have not been conducted and findings in animals were negative. Category C is risk cannot be excluded. There are no positive studies for fetal risk in humans and animals, or no studies at all. However, the potential benefits justify the potential risk. Category D is positive evidence of risk. Data of investigation or aftermarket release show risk to fetus, even though the potential benefits may outweigh the risk. And category X is contraindicated in pregnancy. Animal and human studies or reports on research or aftermarket release have shown fetal risk that is greater than potential benefits. Non-opioid analgesics, paracetamol, most commonly used analgesic and antipyretic during pregnancy and lactation. It is considered as a drug with no teratogenic effect and remains the safest analgesic during pregnancy and lactation. It is usually started at lowest dose and should be used for the shortest possible time. It is classified to category B by the FDA. In this article, where the pharmacological mechanisms by which paracetamol disrupts the offspring sexual development was reviewed, and it showed emerging evidence which was suggestive that intrauterine paracetamol exposure may be associated with certain neurogenital or reproductive disorders in the offspring. In further review of literature, it was noted that in 3 epidemiological studies reported association between maternal paracetamol intake and increased risk of cryptorchidism. Few other articles reported shorter anogenital distance in male infants antenatally exposed to paracetamol. Few other human observational studies suggested the prenatal N-acetyl-P-aminophenol exposure might be associated with both reproductive and neurobehavioral abnormalities in both sexes. There is increased risk of male urogenital and reproductive tract and abnormalities like risk of cryptorchidism, reduced anogenital distance, which are indicators of disturbed masculinization and risk factors for reproductive disorders in later life. Prenatal exposure has been also associated with earlier female pubertal development, can also increase the risk of adverse neurodevelopmental outcomes like attention deficit hyperactivity disorder, autism spectrum disorder, and decreased intelligence quotient. Non-steroidal anti-inflammatory drugs. These are widely used classes of drugs during pregnancy, whether derived from propionic acid like naproxen, ibuprofen, and ketoprofen, phenylacetic acid like diclofenac, salicylates like acetic salicylic acid, oxycans like meloxicam and paroxicam, and indole like indomethacin. Mechanism of action, as we have explained previously, is the inhibition of prostaglandin production by direct inhibition of the cyclooxygenase enzyme. Regarding non-selective cyclooxygenase inhibitors, there is no clear evidence of association between their use and increased incidence of miscarriage when used in first trimester or near conception. The use of NSAIDs in third trimester of pregnancy may be associated with premature closure of ductus arteriosus, which may lead to neonatal pulmonary hypertension, oligohydramnios, which is caused by reduced fetal urinary output, necrotizing enterocolitis, and intracranial hemorrhage. In the mother, it may be related to prolonged labor period and postpartum hemorrhage. Although short-term administration is unlikely to be associated with fetal arterial duct closure, it is common practice to avoid NSAIDs after 28 to 32 weeks until end of pregnancy. In this meta-analysis, conducted to determine whether NSAID used during the third trimester of pregnancy is associated with increased risk of premature constriction of ductus arteriosus, reported that among the 8 studies reviewed with 217 patients exposed to indomethacin and 221 to placebo, the risk of ductal closure was 15-fold higher in the group of women exposed to NSAIDs compared with those receiving either placebo or other NSAIDs. So it was concluded that short-term use of NSAIDs in late pregnancy is associated with significant increase in risk of premature ductal closure. Selective COX-2 inhibitors are categorized to category C until second trimester and D in the third trimester. Non-selective anti-inflammatory drugs have FDA classification of category B up to second trimester and D in third trimester. Opioid analgesics. Opioids are important drugs in the treatment of acute pain during pregnancy. Opioid use in the first trimester has been associated in some studies with cardiac abnormalities, spina bifida, and gastroschisis. Opioid exposure during pregnancy and the risk of congenital malformation, a meta-analysis was conducted and observed that opioids in the first trimester or prescribed for analgesic or antitussive treatment did not increase the risk of overall congenital malformation. The findings should be discussed in caution considering the situation of individual patients and weigh out its potential risk of congenital malformation. As per this forest plot of opioid exposure during pregnancy and risk of congenital malformation, which included 18 cohort studies and demonstrated opioid exposure during pregnancy with 1.3-fold risk of congenital malformation. Opioid use was associated with increased risk of major malformation, CNS malformation, and limb malformation with increase of 57%, 36%, and 127% respectively. There was no significant relationship between the opioid use and cardiovascular malformation, gastrointestinal or ear, face, neck malformation, respiratory or musculoskeletal malformation, urogenital malformation, orogenital clefts, neural tube defects, gastroschisis, or clubfoot were found. Codeine, no differences in fetal survival rate or incidence of malformations were observed between pregnant women who used or did not use codeine. Its use was associated with higher incidence of elective and emergency cesarean and postpartum hemorrhage when used at the end of pregnancy. However, these changes may be due to underlying disease rather than the drug use. It was considered as category C by FDA. Tramadol, a study in pregnant women observed that in 1751 patients who used tramadol at the beginning of pregnancy, with 96 newborns presenting with congenital malformation, out of which 70 were severe. Use at the beginning of pregnancy resulted in congenital malformations such as cardiovascular defects and clubfoot. In more advanced stages of pregnancy, it does not appear to cause major fetal effects unless used chronically and may even lead to neonatal abstinence syndrome. There is no evidence of alterations when used during lactation, categorized by FDA as category C. Morphine. In the first trimester, there are no reports of malformation and must be used with caution. During pregnancy, morphine changes its pharmacokinetics with increased plasma clearance, shortening of half-life, decreased volume of distribution, and increased formation of morphine 3-glucuronide metabolite. Morphine and its metabolites rapidly cross the placenta and establish maternal fetal balance within approximately 5 minutes, and it is classified as category B by FDA. Fentanyl. The use of transdermal fentanyl during pregnancy and lactation is a good option for treatment of chronic pain, though there is only little information on its use in pregnancy, and it is categorized to class C. Methadone and buprenorphine, both are safe when used to treat opioid dependence during pregnancy. Prenatal exposure does not seem to alter physical, cognitive, and language development in children followed up to 36 months of life. Classified into category C by FDA. H1 analgesics, tricyclic antidepressants. The use of tricyclic antidepressants during pregnancy at therapeutic doses does not appear to be associated with increased incidence of malformations. Chronic use or use of high dose near delivery may cause neonatal abstinence syndrome, and the dose must be reduced between 3 to 4 weeks before delivery. Due to many pregnant women who use amitriptyline without reporting toxic effects on fetus, its use seems safe during pregnancy. Amitriptyline is grouped into category C and nortriptyline into category D by FDA. Selective serotonin and norepinephrine uptake inhibitors like duloxetine. The use of duloxetine during pregnancy is associated with increased incidence of miscarriage but no malformations. Near delivery, it can lead to respiratory changes in newborn, and during lactation, less than 1% of drug passes to the milk, suggesting it may be compatible with lactation. It is classified to category C by FDA. Gabapentin. There are only a few reports of pregnant women who use gabapentin with no evidence of increased incidence of malformation. May be related to increased risk of fetal loss, restricted intrauterine growth, and premature birth. Categorized to class C by the FDA. Pregabalin. In a study evaluating 477 pregnant women who used pregabalin in first trimester, was found for major congenital malformations. Moving on to the postnatal period, paracetamol is safe for use during lactation. The estimated dose received via the breast milk is 6% of the maternal dose. Non-steroidal anti-inflammatory drugs like ibuprofen and diclofenac are compatible with breastfeeding. The infant doses relative to maternal doses are 0.65% and 1% respectively. It reduces the needs for opioids, especially in the immediate postpartum period, and the potential risks associated with them. Treatment with single doses of morphine to mother will not be expected to cause any detrimental effects in suckling infants, although the role of active metabolite morphine 6-glucuronide has not been studied. The oral bioavailability of morphine has not been investigated in infants. There is a lack of data for later time postpartum. It is reasonable to prefer morphine in all lactating women. Non-pharmacological management of cancer pain. The non-pharmacological treatment can be used to improve the pain control, coping, adaptation, and self-efficacy. And the common approaches include cognitive behavioral therapy and mind-body approaches. Cognitive behavioral therapy, it helps in maintaining quality of life through improved self-efficacy, developing a sense of control over the illness and its consequences, learning self-regulation skills to improve emotional functioning. It modifies the thinking patterns, gives patients a reality-based alternative version or interpretation of events. It elicits a more adaptive emotional response and improves coping. Mind-body approaches usually used as an adjunct to pharmacological therapy. Relaxation therapy can be transiently used to reduce pain intensity and may be associated with relaxation-induced panic. Imagery creates a positive cognitive and emotional state that can ameliorate pain through recall of pleasant sight, smell, sounds, or taste, as well as somatic sensations. Neonatal abstinence syndrome, it is one of the complications of prenatal drug exposure, a spectrum of clinical manifestations seen in neonates due to withdrawal from intrauterine drug exposure. It is commonly associated with maternal opioid use. The characteristic signs of neonatal abstinence syndrome occurs after chronic in utero exposure to opioids and reflect dysfunction in any four domains, like state control and attention, motor and tone control, sensory integration, and autonomic functioning. Signs and symptoms. There will be disturbances in the sleep and wake cycle of the baby. Baby will be having fragmented sleep with short sleep cycles and difficulty in maintaining an alert state. Alterations in tone or movement usually presents as hypertonicity, tremors, or jitteriness. Autonomic dysfunction like sweating, sneezing, mottling, fever, nasal stuffiness, and frequent yawning are observed. EC overstimulation, sensitivity, or hyperarousal resulting in irritability and crying with any stimuli. Difficulties with feeding, suck-swallow incoordination, and oral hypersensitivities resulting in poor weight gain, tachypnea, and gastrointestinal problems like vomiting, loose stools. Birth weight would be less than 10th percentile for gestational age due to intrauterine growth restriction, and they may also present with cardiac birth defects. Diagnosis. Clinical diagnosis of prenatal opioid exposure is based on history of parental opioid use disorder, positive parental or infant urine toxicology screening for opioids, or neonatal findings that are consistent with neonatal abstinence syndrome. Neonatal testing in biological specimens like urine, hair, umbilical cord blood, or meconium could also help in diagnosis. Management of neonatal abstinence syndrome. Non-pharmacological approach is individualizing the care of infant based on behavioral observations with goal of promoting organization, physiologic stability, and competence. Recognizing signs and triggers of physiologic behavioral disorganization, small frequent feedings or breastfeeding when appropriate, support of infants' efforts to become stable, organized, and competent by identifying techniques that ameliorate the symptomatology specific to each infant. Pharmacological approaches are initiated for infants who, despite adequate and individualized non-pharmacological care, display significant signs of neonatal abstinence syndrome, as defined by the predetermined criteria based on the abstinence scoring system. When two scores are more than 8, we can move on to pharmacological treatment. Score of less than 7 was not treated with drugs as they would recover with swaddling and demand feedings. The common medications which are used in the pharmacological management of neonatal abstinence syndrome includes morphine, methadone, and buprenorphine. A randomized double-blind intention to treat trial of term infants from 8 US newborn units whose mothers received buprenorphine, methadone, or opioids for pain control during pregnancy were eligible was studied, and a total of 117 infants were randomized to receive methadone or morphine from 2014 to 17. The interventions done were morphine of 0.2 mg per ml given every 4 hours and methadone of 0.4 mg per ml given every 8 hours. And it showed the results that short-term outcomes were better in infants receiving methadone compared with morphine. A second medication is used in infants with severe neonatal abstinence syndrome that is not adequately controlled with the use of a single agent. However, data are limited on optimal choice of second agent. Clonidine, effective as an adjunctive medication to opioid therapy for treatment of neonatal abstinence syndrome, and phenobarbital could be used as second-line medication and effective in polysubstance exposed infants, particularly exposed to barbiturates or benzodiazepines. Summary: the decision to use pharmacological therapy should be based on an assessment of risks and benefits to the mother and fetus, taking care to offer all therapeutic options to ensure the well-being of pregnant women, minimize fetal teratogenicity, and avoid chronic symptoms and long-term disability. Thank you.
Thank you, Aswathi, for giving us insights into what are the common agents, what are the causes of pain in pregnant women with malignancy. And you also described about the normal metabolism of analgesics, and then talking about how changes occur in pregnancy in both physiology and pharmacokinetics of drugs. You spoke about the evidence of various analgesic use in pregnancy in various trimesters of pregnancy and what effects it could cause. One of the important things that you mentioned was it's not only pharmacology, we must look at the non-pharmacological management of pain and addressing it as total pain, as we always emphasize. And you spoke about the complications, mainly the most feared complication is neonatal abstinence syndrome. And how would we determine and how would we manage neonatal abstinence syndrome for pregnant women who are on opioids during their pregnancy? So I think you've done an excellent job of taking us through all these questions that arise while managing pain in pregnant women with malignancy. I would like questions or comments to be placed in chat box. Sushma ma'am, would you want to comment on?
Yes, Anuja, this was such a I can say that she has tried to bring all the important aspects, and this is a problem which always, if you will not ask today residents, you will find it very, very difficult, because this is a problem which commonly we will encounter, that pregnant female will come, they will be having pain, and suddenly while doing ultrasound or when they will have severe pain, we will diagnose that she is having gallbladder or breast cancer, most of the time breast cancer, and they are in pain. So it is important that we should know what exactly you should be doing. And Anuja, your resident has really presented it so well. Everybody should know when what to do, what is the importance of using, why we cannot use opioids, and what are the other drugs which we can use during pregnancy. So thank you very much. I think this was such an important topic. Any other comments from maybe Dr. As usual, Dr. Jennifer, or any senior faculty members, those who are here? Dr. Jennifer, you would like to add something?
No, ma'am, it was a very good comprehensive class. So well done. Nothing specific from my side.
Anyone else? I can't. I see this.
I see a question in the chat box, ma'am.
Yeah, please go ahead with the question. Yeah.
Bikash has asked that how to diagnose and treat opioid dependency in pregnant mothers. So again, opioid dependency. Aswathi, would you like to take that question, or you want me to take that question?
Ma'am, you could continue. Thank you.
Okay. So, well, opioid dependency is again something that is a very different topic as compared to this pain management topic. But still, I would try to answer that question for Vikas. So opioid dependency, we have the checklist, right? So all usually, ideally, it should be offered to all checklist. Checklist should be offered to determine opioid dependency or risk in all the patients, youngsters especially, and even reproductive age group females. So definitely using checklist is one of the things. So that is one. Then second, if we determine opioid dependency in pregnant women, the treatment would remain same as compared to non-pregnant women. So opioid dependency treatment remains same, but then we have to be mindful that what effects it would cause on fetus if we use say methadone or buprenorphine in treatment of opioid dependency. Again, when we look at the presentation, if you've heard that methadone and buprenorphine are safe to use in pregnant women, they are class C, and it can be used. I have used buprenorphine in pregnant women, but only be mindful of using opioids, especially during third trimester of pregnancy. Sushma ma'am, would you want to put more insights on this?
I think opioid dependency in pregnancy, again, it will be again very challenging. This can be because of previous like because of the previous physical problems patient is on opioid dependent, or otherwise. I think I would like to address this. It's a very good question. Basically, if I have not come across any pregnant female with opioid dependent, but I would like to address this female uh, close observation plus repeated counseling. I think this will make this is the way I'm going to handle this lady in case if she will present um as a opioid dependent with pregnant female. I think counseling and close observation, and I don't think that anything else we would like to try on this. Dr. Jennifer, I have not come across any female like this. Would you look, Dr. Meenakshi, Jennifer, anyone? And there are so many more questions coming. What should we do for bone metastasis, zoledronic acid, second trimester with pregabalin, sickle cell disease? So go ahead with the one by one. Hello, Anuja?
Yes, ma'am. So
opioid dependency, I think with the counseling and close observation of the female, I think this is the way, this is the only way forward.
So most of the adjuvants that we are coming across, one of the question is about pregabalin. I think pregabalin, Aswathi has already mentioned whether pregabalin can be used or not. So pregabalin is highly teratogenic. So it should not be used in second trimester where organ development is still in process of the fetus. So it may cause teratogenic side effects.
It is absolutely right that we should not use any pregabalin or gabapentin. I think it is a challenge because we don't want to give any medication in first to till third trimester, or especially in first or second trimester.
Norepinephrine is much more safer as compared to pregabalin for use in neuropathic pain in patients with, who are carrying or pregnant women.
So there is a question on sickle cell disease for crisis and chronic pain. Pregnant patient with sickle cell disease.
So Pankaj has put forth a question on.
Pankaj, you answer this because sickle cell patient is in our ward right now, and it is so difficult to handle their pain when they are not pregnant. But you answer this, that how to. Or Anuja, would you like to take up this?
So I have not come across any patient with, of course, one of the things that I would suggest is whenever you have a patient who is pregnant and having multiple morbidities, we should be very mindful of using analgesics. And each time I come across a patient, I would go back and read the literature first before starting any drug for this patient. So I would suggest one word of caution for everybody. Please go back and read the literature, because there is minimal literature available on managing pain in pregnant women. For a specific question like sickle cell disease, I am not very sure because I have not come across, but usually these patients will come with bone pain. And if it is bone pain, we can use non-steroidals and paracetamol very safely. But now there is upcoming evidence about fetal malformations and fetal problems with chronic use of paracetamol. So definitely we should be mindful of using chronically paracetamol as well in sickle cell disease. And second, NSAIDs can be used. So I would suggest that if we are managing such crises, we can use NSAIDs and boluses of morphine. Morphine seems to be a very safe analgesic in first and second trimester of pregnancy. Of course, we should be mindful of neonatal abstinence syndrome in third trimester of pregnancy, and we should avoid using morphine. So I would use a combination of NSAIDs, paracetamol, and morphine, which appears safer in first and second trimester of pregnancy for even a sickle cell disease patient. Madam, anything that you would want to add in this?
So I think this is, This is myofascial pain again. Myofascial pain treating in a pregnant female is going to be a challenge, and paracetamol, as Anuja said, that we cannot continue to giving paracetamol. You have to try medicatamol or NSAIDs in a low dose, but not chronic use for months together. But definitely, if trigger point injection or if non-pharmacological therapy can help, in myofascial pain in pregnant patient, I think non-pharmacological therapy will be a better option. Plus, if it is possible with the trigger point injection with local anesthetics. Praneeth is asking about flupertine. I think everyone is asking very tough questions because it is going to be in pregnancy, because there are no, Pankaj is saying he could not find any guidelines for a pregnant patient. Yes, there are no specific guidelines for pregnant patient, how we should handle. We have learned only this.
Zoledronic acid.
Yeah. Go ahead.
It is unsafe in pregnancy. We should not give zoledronic acid because it will affect fetal development as well. So it is contraindicated in pregnancy. So do not use zoledronic acid or flupertine as well. Flupertine, I have not found any literature, but we should be mindful while using any muscle relaxants or any. Flupertine is highly hepatotoxic drug. That is what we know. So we should be mindful of using flupertine as well in pregnancy.
So see, so many questions and so many different scenarios we are coming across, but definitely it is a challenge. What should we do now? So I think what we have done till now in pregnant patient, if they come, we keep counseling. We try to give non-pharmacological therapy. We try to restrict ourselves with paracetamol and NSAIDs. We have never given opioids to these patients. And definitely all these drugs, zoledronic acid, flupertine, gabapentin, pregabalin, definitely not. But one stage in one of our patient stage came when it was very it's like it was very difficult to balance that pain, severe pain versus a, a child of 2 months and 3 months pregnancy. So you have to balance. It is going to be an individual this thing, and I will look forward that somebody will come with some kind of a research study in pregnant patient, how what exactly we should do, and if we will come across if anybody come across any guidelines, please share this. But non-pharmacological therapy with minimum medication possible, I think, it is the answer.
I see a hand raised.
Anuja, go ahead. Who is raising it?
Yeah, this is Reena George.
Yes,
I just wanted to make a couple of general comments. I think with a pregnant patient, it's always worth getting a rehab or a physiotherapy opinion, because quite often there can be something physiotherapeutic, a facet joint displacement or something that can be corrected. And those are common causes of pain. The second is that, Anuja made a very good point of referring to literature. Similarly, for these patients, even when we prescribe, perhaps we should also give them some information and ask them to think it over a day or two, knowing the pluses, the minuses, and the unknowns, so that they are judging whether it is benefits versus burdens for them individually. And that is the second point. Yeah, and the third thing is for us to be extra careful in our history taking, that this is not a pain which might require other specific treatment, like gastritis or constipation, both of which are also so common in pregnancy and may be contributing to the severity of pain.
Yes.
Thank you, Dr. Reena. Thank you very much.
Those are very good insights, I feel. And yeah, so I have used opioids in pregnancy. In pregnancy, I have had like a couple of experiences with using morphine and buprenorphine in pregnancy. And I mean, we have, only thing is we have not followed up with of course, the patient passed away of metastatic disease, but the child was doing well till 6 months of life. And after that, I had no follow-up with the child. But the developmental milestones were achieved, and we had used buprenorphine a lot in the patient. Morphine we had converted to buprenorphine and continued with buprenorphine, stopping at the 3rd trimester of pregnancy. But 2 patients that I have come across, what I noticed is pain threshold becomes pretty high, and the opioid requirement itself comes down. So we might down titrate our analgesics during pregnancy if we have no choice. That is what my experience is. And I was looking at literature to find out about the pain threshold during pregnancy. And I think these physiological changes also occur along with the other, of course, the known physiological changes. So I think that that's an area of research that we must explore, that what happens to the pain threshold, pain perception during pregnancy. And there's a lot of mental and psychological changes as well that we should be thinking about when we manage pain in pregnancy.
And one more thing, Anuja, the pregnant female herself is understanding everything, because since every pregnant female, at least they understand that they should not take medication for it will harm their child. So it is already if we will take with the other, we have to give opioids, and as Anuja said, that it is really difficult to follow up these children, that what is happening to them. Sometimes it is again it does not happen most of the time. So good.
Yeah, so of course, a takeaway would be from this class, we have to individualize the treatment, be mindful of using analgesics during pregnancy, and mindful of the effect on the mother as well as the fetus and the fetal development. So we must think long term, and also consider the total pain component and explore the options that will be causing less adverse effects in mother and child. and other looking at the total pain management and the pathophysiology of pain and trying to address the pain correctly by minimizing the toxicities and drug use. So thank you very much.
Yes. Thank you, Anuja. Thank you, Aswathi. Thank you, Dr. Reena, Dr. Jennifer, and everyone for good interaction. It was a good interaction. We will see you next week before 6:30. And it was a good interaction, Anuja. I really liked it. Good.
Thank you, ma'am.
Aswathi presented it really well. Thank you.
Thank you, ma'am. Thank you, ma'am.
For presentation, and thank you all the senior faculties who pitched in because this is a difficult topic and it is a matter of discussion more than us coming up with theory. So thank you everyone for attending and putting forth some really important questions for us to think about.